I'm Victoria Reese, and I am the co-founder and president of We Are Ill. We're a patient advocacy organization here to redefine what sick looks like. I'm here with a very special guest. It's been a long time coming, Dr. Alicia Bonaparte, and we're here to talk about medical mistrust in the Black community. As a Black woman living with MS, I'm well aware that the Black community has been left out of the narrative. I'm here to address the elephant in the room and talk about how we can move forward. Dr. Bonaparte, tell us a little bit about your expertise.
So, hi everyone, my name is Dr. Alicia Bonaparte. I'm an associate professor of sociology at Pitzer College. My areas of specialty include medical health disparities, racial health disparities in reproductive health care, and last but not least, also looking at the conceptualizations of teen pregnancy in the US.
Let's start out with defining what is medical mistrust.
So I think you're asking a good question, and in particular, I think it depends on whose perspective you're talking about.
Okay.
So for example, if you're thinking about it from the perspective of a clinician would say, these are the moments in which it seems like a patient is very distrustful of me. They're hesitant towards the things that I say, or they're a little bit resistant to the things that I say.
Okay.
But if you flip it over to a patient would say, I see this person as potentially causing me some harm. In essence, not only harm or hurt in my first encounter with them, but also potentially leading to some type of long-standing consequences.
Right, so they're side-eyeing these doctors.
Yes, very, very much so.
Okay, I got it. Can you tell us, how did we get here? Like, how did we get to this place of medical mistrust as a community?
So unfortunately, this history is steeped in some of the medical abuses that happened during slavery. So when we think about that, what we begin to understand is that Black people, as an oratorical folks, we're storytellers, have shared these kinds of stories. So some of these stories include things like the experiences of Anarcha. Anarcha was an unfortunate patient of Dr. Marion Sims, the father of American gynecology.
Okay, never heard of her.
Yes, her story is just now starting to become much more widespread, and I think part of that is due to Harriet Washington's book, Medical Apartheid.
Yep.
So in that text, Dr. Washington kind of takes us through what actually happened to Anarcha. So for example, she suffered from this condition called fistula. It's a reproductive health condition. I won't go into all of the details, just suffice to say it's a horrible existence to have as a person with a womb.
Wow.
So what you find is that this is Dr. Sims, performed 30 surgeries trying to figure out how to perfect fixing this fistula issue.
30 surgeries.
30 surgeries.
Okay.
And unfortunately, she was never actually cured of the condition. And yet, he is, as I said, is seen as the father of American gynecology. So then you move forward a couple more steps, and this is where we begin to understand what is medical racism, right? And how it actually fostered our present day medical mistrust. So what you find is that the field of medicine, honestly, most of its advances during the 17th and the 18th century were largely developed on the backs of enslaved Black people.
Wow.
So when you think about this question of how was this actually able to occur, what we find is the main contributors were not only physicians, but also pseudoscientists. And I use this term pseudoscientist very purposefully.
Yeah, I'm like, what's a pseudoscientist?
Right, exactly. So in essence, these were individuals that believed in things like social Darwinism, this idea that the Anglo-Saxon race is the best race, these ideas that Black people and other people of color are lower on the spectrum, right? Have these negative characteristics associated with them, like mental aptitude, ability to understand information, and also not necessarily going to be long-lived people either, right? So this idea of just understanding that, they're not a great race, right? So if we think about these things, if we truly, truly sit back and we think about these things, it begins to make even more sense why they justified this experimentation on Black people.
Because that's what they thought. They thought it was the truth.
Exactly. And so when you have a perception or a belief and then you act upon that belief, and that belief then leads to medical abuses, it makes even more sense why they completely justified experimenting on Black people, particularly those who were enslaved. Because again, they lacked power and the ability to really be able to understand what it means to have consent. But I don't want to just stick with slavery, because I think it's important to not just say that it only happened then, because this has moved into our current situation today.
Okay.
The 20th century also heralded a number of different types of medical abuses. So for example, we can think about the story of Henrietta Lacks and the ways in which her cells were taken from her, unbeknownst to her.
Right. Okay. So this is just me, might just be me, but I feel like as a Black person, everybody talks about the Tuskegee experiment. Am I right?
Yes, you're absolutely right.
And not to say that obviously there are other stories and other situations, but
Right.
that is a very go-to situation. And it's usually following talking about not trusting doctors or the healthcare industry as a whole. And it's like once you say Tuskegee, conversation's kind of over or bottlenecked.
And it makes sense, right? Because at the end of the day, right, one, we tend to misname what happened. It was not a Tuskegee experiment. It was an experiment conducted by the U.S. Public Health Service.
Now you're talking because, listen, people talk about this and don't actually know what happened.
Yeah, so what's intriguing is that this was a public health service study that was used under the pretenses of saying, hey, we're going to cure you of syphilis.
Right.
But in actuality, they withheld treatment. And largely the reason why they withheld treatment for the advancement of science is largely to see how and why did the syphilis strain continue to move, continue to grow, continue to expand.
But
and what
correct
led
me
to
if
that.
I'm wrong, the masses typically will say that they were infected with syphilis when they were just not given the actual treatment.
Exactly, exactly.
right.
And so typically what you find in an experiment, right, is that you have an experimental study and a control study. The control study is the group that's not supposed to receive the treatment. The experimental group is supposed to receive the treatment. But in this instance, these men did not receive the treatment.
Right. So how do you think patients feel that clinicians continue to play a part in medical mistrust?
I think there's a number of ways in which we can approach this question, and I really appreciate it. One, I think that patients are oftentimes subjected to, and when we're talking about patients here, we're really talking about Black folks. So what you find is that Black folks understand and recognize that sometimes they don't get the types of screenings that they're supposed to receive, right? These screenings include things for cancer, cardiovascular disease, and most importantly, when we start thinking about autoimmune disorders like MS and like sickle cell, that they oftentimes are underdiagnosed with Black people.
Okay.
Yeah. And what's even sadder is that we can think about now in the 21st century. Jana Mossy wrote this wonderful study in which she was looking and asking physicians, did they perceive themselves as actually mismanaging Black patients? The doctor said, no, we are highly committed to engaging in culturally sensitive care. And yet when you compare their narrative to the actual practice, this is where you see a very distinct discrepancy. They still were mismanaging their pain.
Wow.
And in particular, they would say, well, I didn't see any reaction from them.
Wow. First, it makes me think of, as it relates to MS, how MS is a snowflake disease. So one person living with MS doesn't look like the other.
Right.
The symptoms that one person is dealing with is not the symptoms of the other. So since it's such a broad spectrum of symptoms, it's often very hard to diagnose. So it makes me, like, we have delayed diagnosis already due to that. So if you're now adding this perceived level of, pain tolerance, then that's a whole cluster of things. Like, that's a lot of baggage. But additionally, it makes me think, as we're talking about, not really showing the emotion, if now, as a community, we're ingrained to just say we have to be strong.
Other things to kind of consider too is, again, when we're thinking about people who have autoimmune disorders, right, and they're going to an emergency room, for example, what you find is that sometimes people living with MS are oftentimes not believed. And so in essence, when they say, I'm in pain and I need something, they're actually perceived as drug seekers. So this makes it even more difficult to think about, well, would I actually even trust them if they're not even going to manage the pain the way that I know it should be managed?
It's interesting that you say that, because as part of my MS journey and my story, when I was diagnosed at 25, I was dealing with the very common symptoms of numbness and tingling.
Okay.
And when I went to my doctor, this doctor, after telling him all of the pain and issues that I was dealing with, assumed that due to my line of work, that it was stress. Now, while stress might have been a trigger for what I was dealing with, I was prescribed antidepressants like that.
Wow.
But I'm like, I don't need antidepressants.
And kudos to you for knowing and understanding that you needed to take a different step, because oftentimes patients don't know that. They don't know that they have the ability to do that.
To be honest, I didn't. I didn't. I just went home like, okay, well, I guess I'm stressed, y'all.
Yeah.
And, I didn't get a second opinion. My health continued to not decline, but I still dealt with issues.
Right.
And we had to figure it out, and we did.
Yeah.
So let's dig deeper. Tell us about how racism has affected the training of clinicians or healthcare providers.
Right. So unfortunately, as I said before, medical racism has reverberations today. And as a consequence of that, diagnosis of all types of disorders that Black people, particularly people living with MS, are facing are again underdiagnosed. And then sadly, it's not discussed really well in regards to the training. So the training modules, for example, if we're thinking about skin color, some ways in which you could diagnose is say, okay, the patient appears to have appear blue, but a darker tone Black, exactly.
Okay.
And so a darker tone Black person, their skin is not necessarily going to appear blue. In some instances, it may appear more like a purple or maybe even like a different shade altogether. What's really cool is that there is a medical student in Britain. His name is Malone McQuinde.
Okay.
He actually has created an amazing handbook that's about diagnoses on Black skin.
Wow.
So at least we've had some progress.
What pathways can help the Black community and clinicians work together?
So this is where this concept that we call in medical sociology cultural humility comes into play.
Cultural humility. Okay.
Yeah, and so what's interesting about cultural humility is that this is a willingness for a practitioner to say, I actually don't know that much about your culture, but then portray a willingness to understand and to learn. So the teaching and the learning, right, actually really much so relies on physicians doing that learning, right? So there's a number of ways in which you can do that. I always think to myself about aligning yourself with a patient health advocacy program, like We Are Ill. So for example, getting the perspectives of people who are Black and living with an illness and what those experiences have been like, this is how you reshape what people can do. And it makes people much more conscious.
Right.
And then lastly, considering health literacy, right? How do we help patients learn? And so I think I'll end there in regards to talking about clinicians.
So you spoke about it from the clinician's perspective, but from the patient perspective, if there's still fear, how do we work collaboratively?
Yes, so I really appreciate this question because it really gets at the heart about moving beyond the iatrophobia and actually getting into action.
Right.
And so when we think about this, one of the ways in which we can see this positively happen is employing these individuals that are called community health workers.
Okay.
So what's really dope about these people is that these are individuals that actually come from the Black community. These are people that folks have grown up with, they know, they speak the language of their community.
Okay.
And these people are kind of like cultural brokers between patients, particularly folks from the Black community, and clinicians. So for example, if we can think about like diabetes, right? Among many Black people in the South, it's referred to as sugar. And so in essence, right, that cultural health worker then goes to the clinician and says, hey, like, if they say that my sugar is really bad, they're talking about their diabetes.
Wow.
Right.
Okay. Now let's talk about how the Black community and the medical industry as a whole can move forward from here. I'm feeling like the relationship is still not yet mended all the way.
I think this is where communication comes in, right? There's this concept that we refer to is called therapeutic communication.
Okay.
So the main goal is to make for sure that both parties feel like they're a part of the decision-making process.
Okay.
So if you're distrustful, but then someone says, no, you're a part of this conversation, you're a part of the decision-making process for your treatment as well as the diagnosis, it tends to make a little bit more sense.
Yeah.
Yeah. Some other things that I think are really useful too are informatics, right? Again, informatics are extremely important, but not only just coming from organizations, as I mentioned earlier, and clinicians, but also coming from insurance companies. So again, right, insurance companies are a huge part of the medical industry.
Huge part.
Exactly.
Yeah.
And what you find is a lot of folks simply still won't understand how the medical insurance company work.
Yeah.
Other things that I think are really, really useful too is, again, if we think about this goal of health literacy from both perspectives and all over within the medical industry, I think this is where we really start to see change. When patients actually understand what's happening, when patients feel like they're receiving beneficence. So in essence, you are acting towards me in goodwill. You want the best outcome for me. You actually will embody the Hippocratic Oath of doing no harm.
Right.
That we in society have given you authoritative knowledge. We have told you that you are an expert. You have social legitimacy, you have legal legitimacy, and you have educational legitimacy, right? And you stand by those things and you do those things. And I think, again, organizations like We Are Ill are doing something really important about pushing people to this next point, right? Let's not remain static. Let's actually move forward, right? Let's be dynamic and let's see that social change is really possible. And I think last but not least, when you have people who are working in patient advocacy organizations,
Yeah.
and also when you have people that are called in with pharmaceutical companies, for example, like, hey, let's have a conversation. Tell us, how is our language biased? How is our language potentially off-putting?
Right.
Those are the types of collaborations where, again, you can push back against iatrophobia in really, really wonderful and transformative ways.
Yeah. I love everything you're saying, and I understand it. And it's just so interesting as I'm reflecting on our conversation. Being a person that lives with MS, having an illness, really heavily depending on a healthcare team
Right.
and the healthcare industry, but also having fear and
Yes.
distrust. It's a very conflicting, interesting space to be in because I do depend on that relationship
Right.
to thrive. I do.
Right.
So to have this fear so deeply embedded and be at the forefront at the same time
Right.
of my experience is an interesting one. And I know that our viewers can attest to that and relate. So I'm glad we're having this conversation.
Thank you so much.
Thanks for being here.
Thank you.
I learned so much today having this very intimate conversation about medical mistrust within the Black community. I want to thank Dr. Bonaparte for being here and sharing her wealth of knowledge with us. And I also want to thank our sponsors, Biogen, for making this all possible. We appreciate you.